All right, welcome back, guys. I'm here with Dr. Schnur and Steve Pearson. We're going to talk about Sprint Therapeutics today.
All right, Dr. Schnur here, talking about SPR PNS. Next slide. So let's first talk about the attributes of this 60-day system. As you can tell, the lead is a microcoiled lead, very tiny coils. That's about a fourth of the diameter of those conventional leads that you see for stem. This is good because it actually prevents fibrotic ingrowth around the lead once it's in place for at least 7 to 10 days. It reduces that pistoning sensation and thus prevents really contaminants and decreases the risk of infection. The other thing is, once it's in place, we leave it there for 60 days. Patients can shower, no bath, and then there's no need for a permanent implant. Next one. Across 30 plus peer-reviewed publications, you can see that about 70% of patients report relief, and actually 70% of that population then go on to have sustained relief. So this slide shows several of the common indications that we use SPR for, and you can see that for most of these, the ongoing pain relief, again, is about 70%, and some of them are even more than that. So if you look at the lateral thromboCutaneous, cervical medial branch, occipital, even suprascapular for arm pain or axillary. Some other common examples, low back neck pain. So, we talked about medial branch targets, post-amputation pain, so sciatic targets, nerve or plexus trauma, CRPS, neuralgia paresthetica, where we'd be looking at the lateral thromboCutaneous nerve, occipital neuralgia, inoperable joint pain, post-operative joint replacement, post-hernia pain, post-decompression or transposition of nerve surgery, as well as focal leg, ankle, or foot pain.
So a lot of targets.
Tons of targets. Yes, yeah. If you know of a nerve target, we can target it with SPR, as long as it's not in the face. And the other nice thing about SPR is if you feel comfortable with fluoro or you feel comfortable with ultrasound, either one can really help you place this device.
That's great.
So a little bit more about patient selection. Obviously, you want a healthy nerve target or ability to stimulate the target away kind of from that injured nerve or the region of pain. You would prefer patients who have little to no history of psychological problems. Sometimes we know this isn't possible. We often see patients with chronic pain that have a lot of concomitant mental health disorders, so really using your best judgment is important. Patients who have little or no opioid use are also preferred. So here it lists less than 90 OMEs. I consider low opioid use to be actually less than 50. At my practice, I don't prescribe opioids, but actually I commonly place this device for patients with cancer who may be on very high doses of opioids and have gotten benefit. This next part, the no history of recurrent skin infections and no increased risk for skin infections. This is really about picking the best patient population for the target. I will say that I have placed some of these in patients who previously have had infections or a cellulitis, maybe in the area that I wanted to treat. And with those patients, I certainly discuss the placement with their primary and or sometimes considered consult with infectious disease. This next part, patient has a caregiver that can adequately maintain or care for the system. So some of the leads, right, if they're in the extremities, it's easy for the patient to take the external pulse generator on and off and to actually change the bandage themselves. The ones on the back, especially the one that you're going to see me place now, it's a little bit more difficult for patients. And so you really want to make sure that they have a family member that's there and willing to help them and able to help them. And then this last point, the no history of allergies to bandages or skin adhesives when I was actually a fellow, there were a lot of reactions that we used to see to the bandages that we used for SPR. And since that time, they've come a long way, and I haven't seen the same reactions. The other thing is, if patients know that they have this allergy or trouble with bandages, your rep can certainly give you special bandages like Opsite to prevent any irritation. And I have had no problems. So thankful for that. All right, so time to get started.
All right, let's do it. So what are we going to tackle first?
So we are going to do a medial branch target, a lumbar medial branch. And so I am going to target the L3 medial branch. And by doing that, do I have a...
just ask her to
Oh,
take a shot.
Okay, let's just take a shot and see where we are. Can we go down so I can see? Oh, perfect. Okay, take another shot. Take another. I guess I would just like to see where L5, L4, L3 are.
Can you? I think we're at the limit, so if you could wigwag towards us, just look right here. There you go.
Perfect. Okay, take a picture.
There you go.
Perfect. So we see L5 and L4. Take a picture. Picture. There we go. So right now it looks like I'm on the pedicle of L4. So for me to target the L3 medial branch, I would go kind of 1 centimeter below and lateral to the pedicle. Take a picture. Oh, I'm all for it. Picture. 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 That's where I would start. So before I do this, I would of course anesthetize the skin. In terms of, does this need to be in a full OR? Do people need anesthetic or like a MAC? They don't. Really, local anesthetic works perfectly. Sometimes for some patients, I will give kind of some IV sedation, maybe just a little touch of fentanyl, but mostly just local sedation. So I'll do my skin wheel, and then I'll let them know they're going to feel a lot of pressure. And so right now I'm using what's called the stimulating probe. I'll go down. Picture. And then I'll go down till I feel bump. Picture. Picture. And I would leave it. No. Picture again. I think I'm going through same part or piece of the tissue. There we go. So once I actually hit bone, I would pull back a little, and then I would connect the external pulse generator. And so preferably this yellow cord here, which actually I guess maybe I should show here, would be prepped in sterilely, this yellow part. Yeah, and then the EPG would be prepped out of the field.
Okay, so this is your connectivity device here,
Yes.
right, to test out.
Yeah,
Okay.
and so my rep usually is kind of on the other side of the drape. We will connect. So this would already have been, connected or prepped in, and so I'll connect it, and then I will ask him or her to start turning up the power, which Steve is gonna pretend, and then once we get capture, or once the patient starts to feel kind of a neuropathic type sensation, really in their low back, I'll say, do you think this is in the area of your pain? And they'll say yes, or sometimes they'll say no. And if they say no, then I will, one, go to a different level, or I could try to reposition the needle if they did not feel any stimulation at all.
So these types of patients, you're doing a diagnostic medial branch nerve block beforehand?
So I'm not.
Okay.
I'm not. Who do I offer this to in terms of medial branch SPR? Patients who I don't think that we should ablate the medial branch nerve. So sometimes patients are really young and I feel very conflicted about, burning their medial branch nerves. And then the other times are patients where I think it might be very difficult for me to place my needles because of anatomy, maybe because I don't think that the patient will be able to lay there 3 different times. They're very elderly, things like that. Or we talked about it earlier, a patient with significant scoliosis might be a really good patient, particularly if I think it's going to be very difficult to place needles to do medial branch blocks RFA.
Absolutely, absolutely. And how many, say you have someone who has that lumbar facetogenic pain that you're trying to treat, how many typical leads are you putting in that type of patient?
2. One on each side, usually at the level that I think is causing the majority of their pain. That being said, we all know that the multifidus muscle is innervated at multiple levels, although certainly we're targeting the medial branch. And we're hoping that because of the difference in neuronal plasticity, once this is placed, that these patients will have ongoing pain. We know that we're not curing their facetogenic or their facet arthropathy, right? That'll always be there.
Right.
But we're hoping that those nerves are going to react differently going forward from this. And, it may seem that after you take this away, their pain's going to come back, but actually not the case. And if needed in certain populations, you could do another placement. And what I mean by that, patients who are very elderly, patients who do not want to have anything implanted long term. Most insurances that are covering it make you wait at least 6 months. And honestly, the patients that I would consider this again either have kind of a knockout the park pain relief temporarily, or are getting, like a year or more of relief after I hopefully.
That's great. That's great. So has this changed how you address lumbar facet pain? Quite extravagantly? Were you only doing radiofrequency ablation before that?
Yeah, I was only doing radiofrequency ablation for axial low back pain or facet pain. And now, in patients that I don't feel like that is a great option, I will offer SPR.
Wonderful.
So moving on from this, so we stim, patient says that they feel like they get good coverage in their area of pain. Then I would, disconnect the connector, and then I would take out the stimulating probe. And what I have now is the needle with the lead. And so on the back of that is the garage, which holds the lead, and then a new connector that I can also stim with.
I'll show that one.
Yeah.
I wanted to see kind of how small in size and diameter this is. And maybe a little hard to focus, but yeah. I don't know if you guys can see that, but this is really tiny. It's a really, really small lead. And it might be a little focused, but it might also be just how small this lead is, that it's a very, very thin lead. So great for those places where you're going to have a lot of difficulty, right? So wonderful for a temporary device.
So the next thing I'll do is I'll carefully hold the introducer and put it on. And then again, I'll take the yellow cord and stim again and make sure that we're getting good coverage in their area of pain. Once that happens, I'll remove this.
So it's almost 2 safety checks.
Yeah, most of the time we actually cut this off because there's more than enough lead. But I'll take off the garage. And then where I feel like the tip of my needle is and my lead is, I'll hold kind of pretty good pressure for deployment of the lead. And then after I'm holding pressure, I'll slowly come back with the needle.
And why do you do that? Why not remove the needle without doing that? What advantage does that give you?
Yeah, so we're hoping that the tip of the SPR PNS is actually in the tissue, and this is to try and keep it anchored in the tissue, basically. If you pulled it out, that's okay. Then you'll just start this over again.
You start all over.
Yes.
Right.
No, nothing is lost. So here we go. Pulled it out. If you take a picture, let's see if we can see any. Yeah, you can see the lead kind of just lateral to the pedicle. Yeah, right there. And so the next thing I usually do is I put a dab of glue right where the lead is. Any type works. I let it dry a little bit, although today that won't be the case. And then I put it back in this garage and stimulate a third time. And while I'm doing this part, I'm very careful because this is where you could certainly pull the lead out. And then you want this garage close enough where you can use the manufacturer's device to put it close to the poke site. So I would say here is a good spot for me. So I'm gonna snap it in place. And then I'm gonna get it in the cradle, which sometimes can be a problem. And then I'm gonna kind of put it down right next to it. And then usually you'll want a pair of sterile scissors because you'll cut the rest of this off. You'll get your sterile tegaderm from your local rep, and you see there's a part that actually has like a cotton piece on it. You'll want that part over the tip of the lead as it enters the skin, as well as over the connector with the garage, like this. And then you'll leave the connector hanging out. So if you were to do it bilaterally, a lot of times people do like to put the IPG midline one because I don't know a single person who lays straight on their back just because of comfort. And so they put the external pulse generator in the back and then they connect the leads to that. And we'll have this several bandages kind of next to each other.
Yeah, that's probably the best spot to put it in.
Yeah,
otherwise most people sleep on their side,
yes.
Some on their belly, but most are side sleepers. Yeah, I agree.
So the way I would do it is I would probably put it like this.
Now this technique is good for those who do cases under fluoro, who do cases under ultrasound. It's amenable to both skill sets, right?
Yeah, so we were talking about this just before. What percentage of cases do I do under fluoro and what percentage do I do under ultrasound? I estimated that both me and my partner probably do 90% of these under ultrasound. Wow. And that's because we do a lot of placement for peripheral neuropathies, mononeuropathies. I've done it for cancer pain. I've done it for like pudendal neuralgia that was intractable, intercostal pain, kind of really everything. And I will say that, on the slides I presented with the patient selection, we talked kind of about a lot of things that might make you not want to do it. Sometimes when I'm putting this in, it is the Hail Mary pass. We are in like the last 5 minutes of the game and I'm throwing it. And I have to say that a good percentage of those patients have gotten some relief and they're so thankful that I am willing to try this technology with them. And many of those patients, if they had a knockout of the park, got relief for years and are still getting relief, or after a year, some of their pain has come back and I'm like, yeah, let's try this again.
They're amenable to doing it as a repeat because it's not a big invasive surgical approach.
No.
What do you think is your average length of analgesia? Do you have a sense of like how long most of your patients get out of this? The ones that it does work for?
Yeah, so I will say the patients that I see really getting long-term relief are the people that are saying they feel like 70-80% of their pain has been taken away by this. Those are the patients that get long-term relief. There are some patients that get 20-30% relief and they're happy while it's placed. But then after I take the lead out, most of those would say, I liked while it was in, but I don't have that ongoing relief now that it's out. And so I really see a high percentage of patients going towards the knockout of the park or having that like low level of relief that they're happy with, but that we would need to either consider a permanent or something else for them.
Now, for those watching at home who want to dip their toes in the water, they want to get started, they've never used it before, what's a good introductory case? What's a good starting case for them to get started with using this technology? What would you recommend?
Yeah, so I think lumbar medial branch targets are good. My very first case was actually superior cluneal, which I used fluoro, and I walked along the iliac crest until I got coverage of my patient's pain. That was extremely easy to place. Those two areas I think are pretty simple. And then of course, shoulder pain, if you feel comfortable with ultrasound at all. Also, if you feel comfortable with ultrasound, lateral femorocutaneous has always, I found, pretty much been a knockout of the park. Those are the patients that I've had myself, almost every single one, get longer than a year of relief. And some of those patients have come back after that time.
That's great. That's great.
Yeah.
How about you guys, when you guys are training physicians, Steve? What are the kind of physicians that you usually are most apt to kind of understand this, utilize it, and have good success with it?
Really, anyone that's utilizes fluoroscopy for injections or anything else and ultrasound. So they're all good candidates to utilize this.
Okay, that's great. In terms of if someone wants to get started, how can they get a hold of you? How can they get a hold of you guys? What's the best form for them to connect so that they can ask more questions and get trained?
I think on the website, the SPR website, there's a form that physicians can fill out if they want to talk to a local rep or even be connected with a physician who's willing to talk with them. Like I said, SPR has been a really good company in that they also do a lot of labs really around the country. So if you want hands-on experience, I'm sure that there is going to be a lab near you. And they have people that are experts teaching it. And even sometimes I myself teach it. And you know what? I consider myself good at ultrasound, but by no means am I Dr. Huntoon, who people here will meet later, total expert. And I am always learning from him. And there is nothing wrong with continuing to learn and continuing to perfect your technique. In
Absolutely.
fact, I always feel like no matter what lab I go to, people teach me something new.
100%.
And so it's nice to be able to do these labs and to learn from people. And even people, my own partner had never done peripheral nerve stimulation. And that's because even though she was 2 years ahead of me in fellowship, they really weren't doing a lot of peripheral nerve stim at that time. And so I was trained in SPR as well as placement of permanent devices. She went to one of the SPR labs, and I will say she's done so many of these for low back pain, for occipital neuralgia, for peripheral mononeuropathies, secondary to surgical intervention.
It's wonderful.
Pretty impressive.
Yeah,
Super
that's a
easy.
great adoption rate, and this is a great technology. Dr. Schnur, I really appreciate it. Thank you for coming on. Steve, thank you so much for your help. So Sprint Therapeutics, guys, and I really appreciate you guys coming on. We're going to have Dr. Blake on next to talk about the WIPM annual meeting that's happening in Scottsdale. Thanks again, guys.
Thank you.